I have breast cancer and I have a family.
I have breast cancer and I have a job.
I have breast cancer and I have plans.
I'm in treatment.
I'm triple negative.
I'm metastatic.
I'm BRCA positive.
I'm new to this.
I have breast cancer and I needed someone to talk to.
I needed information.
I needed help with my bills.
I needed to know what chemo would be like.
I needed to know I could do this.
Living Beyond Breast Cancer is a national cancer organization
Created by and for women with breast cancer.
And those who love them.
We provide support and advice,
organize programs and activities
to raise awareness and hope.
I have breast cancer
And I have support.
I have information.
I have advice.
I have breast cancer and I have hope. I have Living Beyond Breast Cancer.
Hi everyone, and welcome to Living Beyond Breast Cancer's Breast Cancer 360. The topic this evening is breast reconstruction, difficult decisions. And we know at Living Beyond Breast Cancer, when you're diagnosed with breast cancer, you have a lot of decisions to make. You have decisions about treatment, you're scared, you're overwhelmed. It's just not a time where you're in your best decision-making mode, and then you have to make a decision if you need to have breast surgery about reconstruction, if you want to have it, and what kind. And what we hear over and over again from women is it's so overwhelming to just take in all the information. So we want to spend the next hour just talking about this, hearing from women who've have gone through this themselves, hearing from our expert, Dr. Lee, and hopefully by the end of the hour, people will feel like this is helpful, that you have a little bit of time to think through these decisions. So before we get started, I just want to introduce myself. I'm Jean Sachs. I'm the CEO of Living Beyond Breast Cancer. For those of you that are new to us, we are a national organization, and our mission is to connect people impacted by breast cancer with trusted information and a community of support. So we are here all the time, many ways to reach us, but the easiest way is just go online at lbbc.org. Tonight's program was generously supported by the Allergan Foundation and our friends at Chico's FAS. They own the brands White House Black Market, Soma, and Chico's, and they are Living Beyond Breast Cancer's biggest corporate sponsor. So thank you to them for supporting us. Anyone who wants to ask questions during this program, we encourage you to do so. You can do it via text, and my colleague Janine will be sorting through the questions, and we'll try to get through as many as we can. That number is 610-365-7532. So let me just quickly welcome our panelists. We have Dr. Clara Lee, who is a plastic surgeon. She came all the way from the Ohio State University College of Medicine. And not only is she a physician, a surgeon, she is also someone who is doing her own research and really does want to help women make better informed decisions. And she'll be sharing that information with us. And then we also have 3 women who generously agreed to be with us this evening to share their stories. We have Susan and Kim and Megan, so you will be hearing from all of them as the program progresses. But let's start with Dr. Lee so we can sort of lay out some of the big issues that you think are important for women to talk about. So if you can just sort of lay out, what are the big decisions women should be thinking about and talking about when they're considering breast reconstruction?
So there are a series of decisions, which is part of what makes it so challenging, and they're kind of interrelated. I think the first step is to take a deep breath and recognize that even though there are so many decisions and they're hard decisions, you have time to make them and to get some help making those decisions. Really, the first one is whether or not to have reconstruction at all. And I think that sometimes that decision gets a little skipped over. That's what I hear from my colleagues here today, and we know from our research. So that's an important one to discuss. And then the next set of decisions is the timing of reconstruction. It can be done at the time of the mastectomy which is called immediate reconstruction, or it can be done later, which is called delayed reconstruction, and there's even something called delayed immediate. Timing is important, and then the type of reconstruction. And probably when you're seeing a reconstructive surgeon, the majority of the time we'll be talking about the type of reconstruction, and there are different types, and which type is best for you is a very personal decision that you should make along with the surgeon. But I think those are the three main kinds of decisions to make.
So you said that, you know, typically women have time to make that decision. Is that always true? Or I think women feel very like they have to keep moving. They need to get to treatment. So how do you sort of help women think about, you could go to have a second opinion, or how does that work?
Yeah, I think the main thing to know is that breast cancer is considered a relatively slow-growing cancer, which is hard for us to imagine. Even just the words, it makes it hard to think that you have time. But in fact, certainly compared to other types of cancers, it is a slow-growing one. And so, which is not to say that you should, you know, take months to decide, but weeks is normal. And it's certainly not the case that you have to have surgery within days. And I know that some women feel that way, and I can totally understand that. But actually putting a break on the process and giving yourself some space to consider what's most important to you, I think that time is worth it in the end.
And what if you know, your breast surgeon often will refer you to the plastic surgeon. And what if you meet with the plastic surgeon and you're either only given one option or you don't connect with that doctor? What would you suggest a woman do?
That's a difficult situation, and it certainly can happen. I think, so I would back it up a little bit, and I think you can prepare a little bit before you see the plastic surgeon, mostly by thinking about what's important to you. And also doing, you know, you can do a little bit of research, but I actually think that the more important thing is to think about how important is it to you to start the process of reconstruction now? How important is your appearance in clothing versus your appearance without clothing? These kinds of things, and we've put them in the resource sheet. So you can do a little prep. And then I think I would say trust your gut. Like, if you don't hit it off with the person, that, you know, that's telling you something. On the other hand, you know, also recognize that it may have just been an off day for you or for them, and perhaps communicate with either the surgeon or the surgeon's office and say, you know, is there a way that we can communicate again? I know that I've had that experience where we just, for whatever reason, we just didn't connect, and then when we talk again, it works a little better. But any surgeon, reconstructive or otherwise, who's worth their salt, I think should be more than happy for you to see another surgeon. I think that is just part of the process, and that should be, you can either get a referral from them or from your breast surgeon or someone else.
And I know you mentioned in the very beginning, you know, for women, they should think about maybe not reconstructing if that's not right for them. And we have certainly heard at Living Beyond Breast Cancer, particularly with younger women, but it may be women of all ages, who are told by their surgeon, well, you're going to want to reconstruct, so we're not even going to talk about this. And they find themselves in a very awkward situation, having to sort of disagree with their doctor.
Yeah, it's so interesting to me that, interesting and sort of disturbing actually, that I think there is a growing assumption that a woman would want to reconstruct her breasts. And I don't think there should be any assumptions about anything, really, but certainly not about something as personal as that. And I have heard that as well individually, and read about it. It is hard to disagree with your provider or to kind of assert yourself. I really encourage women to do that. And I actually think that, I like to think that most surgeons would sort of, they might be a little bit surprised, but most would, I think want to work with you to talk about it. And if they don't, then forget them. They should be asking what's important to you.
Right.
I think, I have had colleagues and friends and patients say, well, like, how can you be disagreeing with the doctor, or what do I have to say? But the doctor may be the expert on medicine, but you're the expert on you. And no one else is. And so you bring that to the table just like they bring the other stuff to the table. So I really encourage you to bring forth that expertise as well.
Right. And I think it's great that you know, as a doctor, you feel really passionately about that. And I know you've been doing some research, so maybe you could just take a minute and tell us about what you're trying to develop to make this easier.
Sure. So most of my research is about how women and their providers make decisions about breast cancer treatment. We've done some research finding that a lot of women don't have full knowledge about the pros and cons of breast reconstruction. And they didn't necessarily, a lot of women also didn't make decisions that were truly consistent with their personal preferences. And so the next stage of research that we're doing is we've started to develop something called a decision aid to help women make decisions about whether or not to have reconstruction and the type. So a decision aid is kind of like an educational tool, but it goes beyond that. It helps you clarify to yourself and to your provider what's important to you. So it pulls the information together with your personal values, and then also helps you prepare to have that conversation with your surgeon.
Right.
So we're developing that tool and doing some work on how to get it best into the hands of women who need it the most and into the hands of the providers.
Right. Well, that'll be really helpful, because we have certainly learned at Living Beyond Breast Cancer, and recently in a survey we did, that while 90% of the women we talked to felt really good about their medical decisions around breast cancer, but only 43% felt good about their breast reconstruction decision. And that is just way too many women. And this is obviously something that impacts your self-esteem, your body image, a whole bunch of things. So let's turn the conversation to some of the women that have joined us this evening. And we know this is not exhaustive. I don't think any one breast cancer story is the same, so there's a million. But let's start with Megan, who was diagnosed at the age of 37. I know that she had 3 kids, I think, under the age of 3, having some twins there. Yeah. In the process of being diagnosed, learned that she was carrying the BRCA gene mutation. And so that really made your decision-making a little bit different than you thought when you were initially diagnosed. So why don't you tell us how you made your decision?
Yeah, it's interesting that you ask about how did I make my decision, because when I look back on the experience, I don't necessarily feel as though there was a decision for me to make. And I do feel like I did my homework, and I felt prepared when I went in to talk to each of my doctors. But having found out that I was BRCA2 positive, it made the decision to have a bilateral mastectomy pretty clear. That's what my doctor recommended, and that seemed to make the most sense to me at the time, and still does. But when I met with the 2 plastic surgeons, they both, I got a first opinion, I did get a second opinion. They both said something similar, and it was, there's basically 2 types. It's immediate reconstruction, where we put an expander in, and then we replace that with an implant several months later. Or there's a a flap surgery where we use your own tissue, but given your body type, we don't think that you're a good candidate for that. So why don't we just go ahead and do the immediate reconstruction? And I think at least what I felt, and I'm guessing a lot of us have felt, is that you're so overwhelmed with all these decisions about your care, about what your schedule looks like over the next couple of months, that just to have one thing off your plate and to have somebody tell you this is what you're doing, that was helpful in a way, but also, I didn't know that there was delayed options. I didn't know that I could have opted not to do reconstruction at all. And so I may have made the same decision again, but I think that I would have felt better about my decision had it been laid out a little bit more clearly.
So you were never given the option to do it later, or?
No, and it's just funny, Dr. Lee and I were talking right before this, and I was relaying a conversation to her. I was talking to a woman who was thinking about her different options, and she had indicated she was thinking of not doing reconstruction. And I was giving a brief summary of the conversation to a male friend, and he said, well, why wouldn't she do reconstruction? And I looked at him, I said, well, why would she do reconstruction? And I realized at that moment that it's all about perspective, and you know, you may be sitting across from a doctor who couldn't fathom why you wouldn't want reconstruction, and they might not even really kind of consider, you know, your perspective about it.
Right. So the decision in many ways was made for you.
Yeah.
So let's move on to Kim, because you were diagnosed 9 years ago, which is great, and you're doing well. And you really needed to start chemotherapy quickly and get moving on your treatment. And you knew from the beginning that you wanted to reconstruct, that for whatever reason, your body image, your self-esteem, that was important to you. So tell us a little bit about, you know, what was important to you and how you made your decision.
My diagnosis, between my diagnosis and surgery was a matter of weeks. So I had to move very quickly. Within 3 weeks of me finding my lump and being diagnosed after several biopsies and finding out that I had 2 forms of breast cancer, I started talking to, I had a wonderful nurse navigator. I had a great breast surgeon I was introduced to, who introduced me in turn to the plastic surgeon. So I had to make decisions quickly, and also thankfully to the internet. So I Googled some things, and one of the main things I was concerned about was my image. I wanted to feel as normal as possible, like myself, and knowing that I'd had to have a radical mastectomy, and in turn I had my lymph nodes removed. So I decided to have the tram flap. To me, it was a free tummy tuck, as well as a new natural breast. And I was very satisfied at the time how well everything turned out. I started chemo immediately because of the stage that I was in. I was in stage 3 when I was diagnosed initially. Unfortunately for me, some issues came about after my tram flap and my breast reconstruction. Although I was very happy with it, I ended up getting some infections and necrosis and other things. I was happy with my surgeon. He was very apologetic of some of the complications I was having, but I wanted to feel natural. I did look natural until some things that started occurring that made me end up having several more surgeries. And it was due to me having chemotherapy. Unfortunately, no one told me that during treatment, sometimes chemotherapy can affect the healing process of the breast surgery. I ended up having that. And,
okay. And I know we're going to talk more about complications, but since Kim has raised this, do you want to respond to that at all? Is that...
Sure. I think it's important to talk to the reconstructive surgeon about how other treatments like chemotherapy and radiation can affect the reconstruction, and then also how having reconstruction can affect those treatments. Because it sounds like you didn't get that.
I didn't get that information at all, and I got it after the fact. During the chemotherapy, in between the chemotherapy and radiation, when I was finally diagnosed as a metastatic breast cancer survivor. So I have metastatic breast cancer. And unfortunately, I guess between the chemo treatment and the actual breast reconstruction tram flap, totally gave this right breast a problem, significant problems.
Okay. Janine, I think you have a question?
Yeah, Dr. Lee, should the breast surgeon discuss the option of no breast reconstruction or leave it up to the plastic surgeon to have that conversation?
I don't know. I think it could be the responsibility of either. Probably both. Like, I think more information is better. But it depends a little bit on what rapport you have with each surgeon.
Okay. Well, let's move on to Susan, because I think you can share a personal perspective on that issue. And I know that you were diagnosed 15 years ago with early stage breast cancer, and you had the choice of a lumpectomy or a mastectomy, and you decided to do the lumpectomy and then ended up sort of needing a partial mastectomy. So tell us about your decision not to reconstruct and how it all played out for you.
I really did like my my breast surgeon quite a bit. He did suggest right from the beginning, though, that I did have a mastectomy. and reconstruction. He did make the whole thing sound as if I was going to the store to get a quart of milk. We're going to remove the breast, we'll put the stretchers in, bada-bop, bada-bop, and you're back to normal. He made it sound as if like 2 weeks later I'd be like dancing around naked at the spa, you know, like, yay, I'm all beautiful. Unfortunately, that's not the reality. And I also didn't feel as if I had time to think about it. I felt as if it was like an immediate thing along with everything else that entailed. And I also feel that, you know, we all have our own idea of how we feel about the word normal and whether or not what it is normal to us or each individual person. Does it matter to you if you have your breasts or not? If it matters to you, then you should have reconstruction. But I do think that you should be able to get the information. Like you were saying, it's really important to take time. But I don't think that when we're in that position where somebody says, hey, you have cancer, that you really feel as if you have time. To you, as soon as someone says the word cancer to me, I have a long family history of cancer, and nobody made it to survive. And I felt there was a big clock ticking, and I had to make this decision like today, or I'm going to die. And I wanted to live as long as possible, as well as possible, and be the person who I felt I really am. So if things are changing in the medical community where they're going to give you time to think about it and going to give you time to talk to different surgeons rather than just one, then that's an exceptionally great thing. But I think that we should also be given the option of going flat and recognizing that this is just as an important and valid place to go.
Yeah, and that's good.
One comment I have about what Susan just shared is, you know, just about this whole clock ticking as soon as you get diagnosed. It almost felt like the conversation that I had with my surgeons was, I don't want to say superfluous, but I mean, here I was talking about, you know, my life and what chemo was going to be like and, you know, all of these other kind of, I don't want to say bigger issues than what was my body going to look like. And so I think that while, you know, there's a lot to consider and there's a lot of decision making, there's this cloud over that's, you know, while I want to spend a lot of time on that, I have to spend a lot of time researching what my cancer looks like. And so it's, you know, it's just, there's a lot to balance.
Right, and I think that is the most common experience that we hear, you know, that the breast reconstruction decision is just sandwiched in between everything else.
It feels a little bit, I mean, I felt a little bit vain looking at different, you know, options, because I was like, well, you know, I should really be focused on other things.
Right, right. So up on the screen, Living Beyond Breast Cancer did create an infographic to help women just sort of walk through the decisions, and you'll all have access to that. But as you can see, it's not a really simple infographic, and there are a lot of information in a lot of different places where you have to make decisions. So that is just a resource. And just before we move on to the second part, which we're really going to focus on complications, maybe we could start by saying, do you feel, Dr. Lee, that women are given realistic expectations when they have that meeting with their plastic surgeon about what it's going to look like afterwards? And, you know, what do you think is happening in those conversations?
Yeah, I think it's probably all over the place. We do know, partly from some of the research that my colleagues and I have done, that what the provider thinks is important to you is not necessarily what is important to you. Like, that we've actually asked providers, what do you think patients care about? So I do think there can be a disconnect. It's one way to start to get at having the right expectations is I think that surgeons should describe to you what to expect in terms of what the surgery is like, what the recovery is like, including the immediate recovery and the long-term recovery, and then also what you can expect to look like both in and out of clothes. And then also, really importantly, which I think also gets overlooked sometimes, is what you will feel like, meaning not only just sort of, you know, I think we don't talk about feeling and sensation or sensibility enough, but how you'll feel when you're just there, and then how you'll feel when you touch yourself, how you'll feel when someone else touches you, and we kind of forget that, and I don't really know why. I think that a surgeon should show you photographs and give you a sense of what you're looking at in the photographs. Like, this is a typical outcome, this is a not so typical outcome, this is a good outcome, this is not a good, you know, those kinds of things.
And do you feel like that's happening, or is that the exception more than the rule?
I think a lot of that happens, but maybe not always. I think like a thorough initial breast reconstruction consultation, I think it generally takes about an hour. I mean, probably, you know, maybe 40 minutes, but, and then often multiple conversations. So what's typical in my practice is it's about a 45-minute to an hour conversation, and then 1 or 2 phone calls after, and then possibly another visit to talk about the decision, and then a preoperative visit right before the surgery.
Did you guys all have that many visits?
I should have gone to Dr. Lee.
Yeah, I was going to say the same thing. When she says there's a disconnect,
yeah,
I'm not knocking male plastic surgeons, but it seems to me what you offer as a female doctor would have been something I would have preferred, to spend some more time talking to me. Because it does feel, now that my memory serves correct, it was like rushed. Not like rushed, like, okay, let me hustle you out of here, but more so not spending that time talking like how another woman would.
At you.
Yes. And there is always going to be, there was that book used to be Men Are From Mars, Women Are From Venus. There's always going to be that. Whereas if you would have been my plastic surgeon, I would have appreciated more thorough conversation. I probably would have felt more comfortable crying or venting while we discussed some options. Not to say my plastic surgeons were awful, that's not what I'm saying, but when you said 45 minutes to an hour, I can't not relate, because it does seem like a doctor looking at the clock, okay, 20 minutes tops, I gotta get in and go see the next patient. It would have been nice having more conversation, more visual aids, more of that.
Right. So before we want to get into sharing some of the complications that all of you experience, but before we do that, Dr. Lee, I know that for some of the people listening, they live in rural communities, they may have to travel hours or even fly to see a plastic surgeon. I mean, do you feel like, depending on where you live, that changes what you're offered? And
yeah, so we do know that where a woman lives is associated with whether or not she has reconstruction and what type. And some of that, you know, is not surprising. If you live really far from a plastic surgeon, it's harder for you to have reconstruction. And some of those things are like access issues that I think eventually could be worked on, but some of that is, we could still do a better job. Like, I think surgeons, even if you are coming from really far, you should still get all the options. You should still be asked all the questions. You should still be able to communicate how you feel. And then you can work on the logistics, and maybe the logistics won't allow you, for example, to have a tissue expander because you have to come back every week for expansion or something like that. But at least to know what's out there, I think every woman deserves.
Right. Okay, great. So Kim, I know that you had a lot of complications. You've sort of hinted to that, and it really took you nearly 9 years to, I think, feel at peace. So, well, we can't talk about all 9 years. Maybe you could just give us a window into what happened versus what you expected to happen.
What happened was necrosis, serious necrosis, infections. The breast tissue got really infected from the chemo. Whereas I wish I had known prior to it, because ironically my plastic surgeon did apologize profusely how sorry he was. He we had had the time maybe to further discuss postponing the tram flap, because of my aggressive chemotherapy kind of gave me some infections, and I was hospitalized several times with infections, and then we had to redo the surgery. And so whatever the tram flap did initially, where I felt beautiful again, I didn't feel so beautiful after, because I lost so much tissue. So that was the second surgery. Then there was a third. I had my final surgery this past September, and I'm very pleased, finally. More necrosis, but not as bad, but it was upsetting to the point almost for a year I'd been kind of dealing with it back and forth. So this time, I appreciate the fact that my plastic surgeon here explained to me that it doesn't mean the necrosis may not come or pop up again, but we did something that I hadn't done before. Because of course I didn't have necessarily any fat to put in there, so I did decide to do an implant, and I'm very happy with it. I'm feeling, I healed so quickly from this surgery, whereas the last several surgeries, it was an ordeal. I didn't even take my pain medicine except for the first day recently, and I was back to myself. I'm back to sleeping comfortably. I even enjoyed looking at myself again. I actually showed my daughter what I looked like recently last week, and I haven't had that much confidence in a while because of the complications, because I felt the complications made me look horrendous, that I wouldn't even look at myself anymore, and that's not a good feeling as a woman.
So maybe you can help have everyone understand what happens with necrosis and how this plays out.
Necrosis means tissue dying, basically, and it generally happens when there isn't enough blood flow to the tissue, and that can happen if you have a tram flap, which is transferring tissue from your tummy to the chest. If there isn't enough blood flow to the tissue, some of the tissue can die. And the issue with chemotherapy is that some forms of chemotherapy suppress your immune system or your ability to fight infection or your ability to heal. And so if you have surgery and then have chemotherapy right away, you may not have healed completely, and then you have chemotherapy, you're more prone to having problems. You're not necessarily more prone to have necrosis, but if you have necrosis and have chemotherapy, then that necrosis can be more of a problem.
Right. Okay. Janine has a question.
Is that also associated with other types of systemic therapy like Herceptin?
So Herceptin, I don't think there's good evidence about how Herceptin affects healings, but we generally recommend a few weeks time between Herceptin treatments for surgery.
And also another quick question, folks are asking if they can participate in your research.
Oh, yes. Yeah, that would be really great. And we're actually, my research team is collaborating with Living Beyond Breast Cancer, and so that's certainly one way to collaborate, and I would really welcome that.
Yeah, that's great. So we'll be providing more information. So before we move on, what do you think Kim Surgeon could have done that might have helped her prepare better for this?
Yeah, I think that, I think it's the surgeon's responsibility to be thinking of all these like complex medical issues, and then ideally also be telling you. And then I think also the surgeon needs to be communicating closely with the rest of your oncology team. I imagine they did, but I don't know. I have the luxury where I work of having, first of all, we're all in the same building. We meet for an hour and a half every week, meeting the different teams. So the medical oncologists, surgical oncologists, radiation oncologists, reconstructive surgeons, the radiologists, and the pathologists. And there are a lot of institutions that do that. So we're guaranteed to talk about these kinds of issues. But if your surgeon doesn't have that, they ought to be, either communicating individually through some other way about how the other treatments are going to influence each other.
Unfortunately, my breast surgeon, he retired a month after they didn't communicate that well. And the oncologist and the breast surgeon, the plastic surgeon didn't really communicate often, which was unfortunate.
Yeah.
So let's get Megan into the conversation, because I know for you did have some complications with your implant, and also not feeling prepared about what it was going to be like.
Yeah, I think, and you touched on this a little bit, but was really about expectations. And you talked a lot about some things that can be done between the patient and the provider. But one of the other, I think, facets that we didn't touch on is the expanders. And I think maybe from a surgeon perspective, they're temporary, they're not going to be in that long, they're uncomfortable, but you know, they get removed and you get replaced with implants. Well, waking up from surgery, I mean, I could hardly take a deep breath because it was so, my chest was so tight. I could hardly, you know, it really was difficult to, you know, to take a deep breath. But the expanders for me were so incredibly uncomfortable. It felt like there were rocks under there. I mean, I know there weren't, but they were angular. They were hard as a rock, and just so incredibly uncomfortable, and didn't look natural at all. Because I think what I was expecting, which is what my doctor said, was, oh, you know, you'll wake up and you'll have something there. They'll probably be about the same size as, you know, your breasts before we did the surgery. And so in my head, I'm thinking, okay, so this isn't going to be a huge difference. And then to wake up to you know, just sort of what I would say was a mess. You know, that was about expectations for me. In terms of complications.
But wait, before we move on from that, because we hear that all the time about.
I mean, it was poking my arm, like
how painful the expanders are, how uncomfortable, how women can't wait to get them out. So what's happening in the doctor's office that they're not, you know, having some expectation? Because I would imagine if you had the expectation, maybe
like this is going to be terrible, but it's finite and it's going to be uncomfortable. I mean, at least then you're going into it with.
Yeah. That's awful. But I think that I'm guilty of what you described, of being like, well, it's temporary, so let's talk about the really important stuff, but that's actually important. So I think that some of it's that there's like, oh, that's just temporary.
Don't worry about that. We'll fix it. Yeah.
So that's where I think, you know, women learning from each other is so important. Why we do these programs, but do other things.
And it's also don't freak out when you wake up and it feels like that. I mean, I wasn't sure if that was right, if that was, you know, if I should be overly concerned about it. So I think there was also an anxiety level when it was so not what I expected.
But then I know you did have a different complication, so maybe you could tell us about that.
Sure. For implants, I got to choose between round implants or the anatomically correct ones, which are sort of a teardrop shape. They're wider at the bottom and narrower at the top. And so I decided to have those because they would maybe be a little bit more natural looking. So I had the surgery, which I was thrilled to get the expanders out, and the second surgery to put the implants in was you know, easy. Right afterwards, you know, I was a little bit sore, but everything was fine. But over the next several weeks, several months, I just felt like they weren't quite right. Yet I didn't really have a bar to measure that on, but they felt a little bit too full on the sides. They looked a little bit odd to me when I was getting dressed. But again, I thought, well, this is a whole lot better than the expanders. And I didn't have a sense of what they should have looked like. So I did go back several times to my plastic surgeon. He said, well, let's just give it another couple months. Let's give it another month. So I kept going back. And my younger sister, actually, who was also BRCA positive, had a preventative mastectomy and used a different doctor. She was in a different state. She saw me and she said, you know, you might want to talk to my doctor. And I said, okay. So I went in and she took one look and she goes, oh, that's not right. And she then replaced my implants with round ones. So essentially what had happened is the anatomically correct ones turned sideways so that the bigger part of the breast was under here and the narrower part was in the middle. So I was very thankful that she identified it and was able to fix it. It was a little bit frustrating that I had the sense that something was wrong for so long, but you know, it wasn't sort of appreciated at the time. So you know, it ended up okay, but you know, it was a process. And just one other thing to add about that is I had done my homework. I knew that was a risk, and I specifically talked to my doctor about it. And I said, look, I know that there's a risk with these anatomically correct breasts, implants. How comfortable are you, or have you had this, you know, have you had this complication before? And the response was, oh yeah, that happens, but it's never happened to me. And you know, I kind of find that hard to believe, given that he'd supposedly done thousands and thousands of these. surprising that I would be the first, but maybe I was. But again, I felt like I was asking the right questions. And
Is
you know,
that
that's
something you know about or have heard about?
Yeah, I mean, for sure, that's one of the risks with the shaped implants. I think, yeah, I mean, it's important to know the risks. I think.
Yeah, and there's no guarantees. I get that.
Yeah,
right?
unfortunately, it can happen.
Yeah. So Janine, you have a question?
We have a number of questions about complications, but before we even jump into them, Dr. Lee, what percentage of people who have breast reconstruction will encounter a complication?
Yeah, so the best study on this was published about a year ago. It was a large 11-site prospective study that found that over the 2 years after breast reconstruction, the rate of a complication is about 33%. So one way to think about that is if 100 women have breast reconstruction, 2 years later, 33 of them will have had a major complication, 67 will not. So it's still the case that most don't, but it's a significant risk. Now, why they used 2 years is because, as many people here know, reconstruction is a process that things can happen later, and also you might have more surgery. And so they looked at like what I think is like the true experience of having reconstruction, which is like that sort of window during which complications can happen later, like the implants turning.
Right. But I'm sure the doctors aren't necessarily wanting to tell you that. Go ahead, Megan.
No, I was just going to say, I think before being diagnosed with cancer and going through the whole cancer experience, I used to think of side effects like on the side of a Tylenol bottle, you know, that says, you know, 0.01% are going to have a headache, or, you know, or something like that. And then when I started reading more about, the, you know, whether it's the side effects of chemos, but also, you know, about reconstruction, I was really reading these thinking, wait, 1 in 14 have this, you know, have this problem, or 1 in, you know, 1 in 10, and so, and what you're saying is that it's, you know, much higher than that. So
Yeah,
I mean, I guess what I'm saying is I look at these numbers in a much more real way.
Yeah.
And your hope would be if women went into this knowing that you know, there is a higher chance of complications or things to look out for, they might manage this better, right? Is that part of what you're...
Well, I think there's a couple of things. One is that not all surgeons know this information either. So the idea behind developing a decision aid is, you know, you get that decision aid or you get information similar to what Living Beyond Breast Cancer is providing, whether or not your doctor tells you. And so you're not dependent on that variability. But then also, I think there are, so one thing is if you knew that risk, then you feel a little bit better if it happens to you, that you know, at least it's not a total shock. But also, it's sometimes possible to see where you fall on the spectrum. So you may be higher risk than the average, and so it's good to talk to your doctor about that. And there might be some risk factors that you can change. And then there's maybe some that you can't, and that might change what decision you make about reconstruction.
I know Janine has more questions.
Yeah, we have a couple of questions. So one of our individuals watching said she's had a double mastectomy with silicone implant reconstruction and has had capsular contracture on the radiation side several times. Physician is now suggesting tram flap surgery and is wondering, is there anything else that can be done about the I don't want to try and pronounce it again, but if you could explain to folks what it is, how it develops, and is there anything people can do?
Yeah, so the capsule is basically a layer of scar tissue that forms around the implant. Everyone has that layer, and contracture is a long word for it shrinking or getting tighter around the implant, which makes it both potentially uncomfortable, but also not as natural looking or feeling. That happens a little bit in a lot of implant reconstruction. It happens pretty often. Some surgeons think always when the radiation is involved, either before the implant is placed or after, if you get radiation of the reconstructed breast. The mainstay treatment really is to replace it with, if you've had radiation, is to change it to a flap. And that's because if you haven't had radiation, you can just remove some of the scar tissue and replace the implant. But if you've had radiation, we know that the scar tissue is pretty much going to come back. There are some adjuncts you can do, like fat grafting. So I think it's worth at least asking your surgeon if that's an option. But largely, it's changing to a flap.
Okay.
And the next question is about someone who had saline implants for 19 years and then switched to a silicone implant, and she's feeling ill and has been diagnosed with a number of different diseases and is considering going flat after this experience, and just wants some feedback about any connection between autoimmune diseases and silicone implants.
Yeah, so there's no evidence that silicone implants are associated with autoimmune diseases or really any other diseases. And that's based on a pretty long history with breast implants. But if she doesn't feel comfortable having her implants anymore, it is certainly an option to either go flat or switch to saline implants. But right now, we meaning like the community that looks at this evidence, we don't have any reason to believe that silicone implants cause autoimmune diseases.
Right. Thanks for addressing that. And one last question on side effects. How common are seromas along with low-grade cellulitis?
So I don't know the exact number on seromas, but I would say overall they're pretty common. They're not that bad either. Usually they get better, but every once in a while it requires surgery to fix them. And then seroma is a fluid collection. Okay. And it's more common if you have, it's most commonly in the site where you had, if you have a tissue transfer, like a tram flap or a latissimus flap, in what we call the donor site. In other words, in your tummy or in your back. They're pretty common in those locations.
Okay. And we have another little worksheet that we created and Dr. Lee helped, which is some questions to ask your doctor about breast reconstruction. And just a lot of them we've talked about, but just another thing for you to share with others or to think about to make sure you get your questions answered. Do you have some more questions?
Well, the one question I have for our panelists is how many of you felt that you had these kinds of conversations about complications and even about the specific complications that you might encounter with the type of surgery you ended up getting?
I mean, mine was, it was me asking the question of, I know that they turn, I read that, and it was very dismissed.
For me, I believe I felt I did enough research, but I guess you can talk to your doctor as much as possible and still do research, but your body will do its own thing, I believe. Am I right, Dr. Lee? It's just your body, you don't know what your body is going to do. Each person's different. It's funny, like you mentioned the seroma. When I had the tram flap, one side eventually started protruding, and we had to do something with that too. You don't know what your body's going to do, and the treatments in combination with that, and it just, like they say, our bodies are a mystery. You know, we never know.
One other comment that I think would have been particularly helpful, or was particularly helpful for me in terms of expectation, was the recovery, and that can be a whole other panel discussion. But I had, as you mentioned, Jean, I had little kids, and
Susan, a woman always has to take care of herself. Her hair was done, her nails were done, she was outstanding, and she was flat, and she was beautiful, and she always was empowered right until the last minute. And I guess I just wanted my surgeons, my oncologists to feel that was possible for me too. So
she sounds like an amazing woman. So
she really was.
Sharing it. We haven't really talked about the advantages of delayed reconstruction. So since both Megan and Kim had immediate, do you want to talk? Can you talk a little bit about that? And
sure. The main advantage of delayed reconstruction, in my mind, is that it's lower risk. So, that 33% number was for immediate reconstruction. So I don't know that we know the exact number for delayed reconstruction, but we do know that it's lower. So it's certainly something to consider, especially if you have risk factors for a complication, like some risk factors are having really large breasts or having really long, in other words, droopy breasts, or if you have diabetes, or if you smoke, and there are some other risk factors. The other advantage of delayed reconstruction is it just kind of buys you some time. So if you feel kind of overwhelmed by this process and you want to focus on like the cancer treatment, it does give you an opportunity to sort of like do that and then deal with the reconstructive issues later. There are a couple things though that are not really possible if you have delayed reconstruction. They sort of are, but it's a little complicated. So I encourage you to talk to the surgeon, which is nipple-sparing mastectomy is often not possible with delayed reconstruction, but not completely. And then skin-sparing mastectomy is usually not done also with delayed reconstruction, but it can be. Those are the main things. And then if you need radiation, so if you have a mastectomy and then have radiation and then want reconstruction, you pretty much have to have a tissue transfer. So there are some things that you do that are a bridge that's burned, but most of the time there's not.
Right, so there are trade-offs, so it's certainly something. I mean, we have known people at Living Beyond Breast Cancer over the years who have said, you know what, I've got young kids, I'm gonna wait 5 years and then I'm gonna figure out exactly what I want. And in those 5 years, I'm fine, not being reconstructed, but I think it's just an individual decision. I know you have another question.
Yes, we have a number of questions. This one comes from Catherine Guthrie, who recently authored a book called Flat, Reclaiming My Body from Breast Cancer. And she is asking Dr. Lee, all three of our panelists didn't have enough information to make a decision that they felt good about. All felt rushed, dismissed, or discounted. What are surgical societies doing to train breast surgeons to do better?
What are surgical societies doing?
Or any of the professional associations.
Yeah, I mean, I can only really speak to my own professional society, which is the American Society of Plastic Surgeons. So in the research that I described, they are one of our partners, along with Living Beyond Breast Cancer, to develop this decision aid and to develop a way to implement it and get it out to the people who need it. So our society is also trying to specifically address complication risk for breast reconstruction. I'm not sure what the other societies are doing.
But clearly something that for women, this is something you need to think about as you make these decisions and get to the doctor that is, going to be respectful. But I think you can ask.
And actually, this one, to get this one in, we have a couple of questions from men who had breast cancer and who were not offered reconstruction, and just wanted your input about whether there are unique issues for men who are seeking reconstructive surgery.
Yeah, for sure. So I think there are several unique issues. One is that it's less common, and so I think that there aren't as many resources for men. The experience of being treated in offices and clinics that are most of the patients are women, a lot of the services and the pictures and all of that are women. I imagine that can be a difficult experience. And then the actual disease treatment and the course of what the treatment is like and how it goes, and then it is different in male breast cancer, and therefore the reconstructive issues are also different. Plus, men's bodies are different, so the actual surgical procedure is different, but more importantly, the cancer treatment is a little bit different.
Okay, well, thank you for addressing that, because we do have programs and things to support men, so it's important to bring that into the discussion. Yeah. So I know we're close to running out of time, so should I have everyone, Janine, you're looking for more questions, but while she's doing that, if each of you just wants, for people out there that might be watching who are in the middle of making decisions, if you just have like a little bit of advice for them, and then Susan, we'll start with you and just go down the line.
My advice would be to go with your gut feeling, go with your heart. You want to go flat, don't look back. You're still an amazing, most beautiful woman on the planet. And don't feel rushed into reconstruction. Make your own decisions.
My advice is to discuss it in more detail with your whole surgical team. Particularly if you have to start immediate chemotherapy and radiation treatment. If I had known now, what I know now then, I probably would have done delayed reconstruction. Yeah. I know for a fact, I could honestly say today, I would have waited and not been so worried, concerned about my own vanity. Whereas I had several things going on. I would have taken my time and worried about getting well, my wellness first. I had 3 children, my youngest being 12, going on 13. And I needed to focus on my wellness and making sure they were fine too, because in your journey, your family's going through it with you. So I would have waited and spent more time talking to my surgeons and maybe even seeing 2 plus another second opinion, because I basically got referred by my surgeon. Mm-hmm. So I would have talked to 2 surgeons.
Mm-hmm. Right. Thank you.
Yeah. I think Dr. Lee actually had a great suggestion about just take a breath and give yourself some time if you can. I know I certainly felt like, oh my gosh, I have cancer, get it out. Let me schedule this surgery. Da, 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 da. And I think to be able to just take a step back, breathe a little bit, explore some of these options like delayed reconstruction. I didn't know that was an option, and that sounds, certainly worthy of consideration. So,
great. And what about you, Dr. Lee?
Yeah, so one is that it is an option not to have reconstruction, and it's one that you can then revisit later. The other is what I said before, which is that you're the expert on you. And just remember that. And so bring that expertise to the conversation. And then lastly, I think breast reconstruction is a journey as opposed to like an event. It's really a process that it is not a one-time deal. It's a process. Now, ideally, you're taking that journey along with your surgeon and a number of other people, but it unfolds. It doesn't happen once. And so if anyone tries to describe it to you as otherwise, I don't think that that's correct. But it's also it can be a gratifying journey, but it is one that takes investment.
Right, that's helpful. And I just spoke recently to a 41-year-old who just finished treatment and did immediate reconstruction like all of you. And I said, so how are you feeling about it? And she said, I look great in clothes, but when I take my clothes off, I'm like, why did I do this? So I think that you are not alone in how this feels, and clearly women need to really think about what's important to them. So you're the expert on you is great. I'm gonna remember that for sure. So I really wanna thank all of you for spending this hour sharing your story and sharing it so openly. We really appreciate that. And Dr. Lee, for your compassion and all you're doing to help women. And I hope this resource tool becomes available and really will help those that come next, because that's really why we do all this work, right? So it'll be easier for the next person. So remember, we have resources at lbbc.org. We have the resource sheet and the infographic. We also have, we often address this issue on our public Facebook page, but Living Beyond Breast Cancer also has a closed Facebook page. And there is a lot of conversation about breast reconstruction. So if anyone wants to join that, just email us and we'll send you an invitation, because there's a robust conversation going on right now, echoing much of what we've heard tonight. So I just want to once again thank our sponsors, the Allergan Foundation and Chico's FAS. I want to thank our audience here in Philadelphia, and thank you for joining us. Nice. Everybody can relax.